In this particular example, benign positional vertigo could not be confirmed either by the testing modality or observance for torsional nystagmus on the screen. The last two examples came from Hallpike testing in two different patients in the left ear. In these particular examples, there is pure vertical nystagmus, which is observed, which is always indicative of a central lesion. It is again of prime importance that the operator observe the direction and the type of nystagmus during the Dix-Hallpike testing maneuvers. The next portion of the positional testing battery demonstrates the response to placing the patient's head and body in various different positions. Typically, these include supine head center, supine head left and right, body left and right. And these are done separate from the Dix-Hallpike maneuver for benign positional vertigo. Typically, these are static positions with slow changes, and there are up to or over 20 possible positions. However, the aforementioned positions are typically those that are most commonly employed. Recording is done for some 10 to 20 seconds, and certainly longer if symptoms are noted or nystagmus is seen. This can differentiate a peripheral from a central vestibulopathy, with peripheral disease being diagnosed if the nystagmus direction is the same in all positions, while central disease is noted if there is direction changing nystagmus in a single position. There is also a non-localizing finding when nystagmus direction is changing with changing head motion, or dizziness complaints that can be elicited when the patient is moving into various different positions. This particular testing demonstrates an evaluation of the patient's response when being placed in the supine head right position. As will be noted, there is an upbeating or right beating nystagmus in this particular position. In this patient, there was no response to Dix-Hallpike testing. However, an extremely brisk response, as demonstrated by 6 beats in 10 seconds to the right on the supine head right positioning. This is indicative of horizontal canal benign positional vertigo and is presented as an example of a phenomenon which occurs in only 1 to 2% of benign positional vertigo patients. However, this is an abnormal positional finding and is demonstrated for educational purposes. Additional examples of positional testing are presented at this time. In the first two tracings, there is noted both a significant horizontal and vertical component in body left and body right testing. Even though this is not specifically Dix-Hallpike testing, there is an example in each case of torsional nystagmus, which in fact is indicative of benign positional vertigo. This demonstrates how important it is to observe the degree and direction of nystagmus during this testing modality. The next 4 examples demonstrate negative positional testing in supine head center, left, right, and body right. This would be a negative result and would not be considered abnormal, but simply no score is present. The next 4 examples demonstrate abnormal positional testing, which includes supine head left, body left, supine head right, and supine head left. In this particular case, greater than 6 beats of nystagmus in the horizontal channel are observed during a 10-second testing session. These are clearly abnormal positional studies. The final 6 studies demonstrate pure vertical nystagmus in a variety of different positions. This again is indicative of a central vestibulopathy. It should always be remembered that pure vertical nystagmus is not indicative of any peripheral lesion, but is diagnostic of central vestibular disease. The final portion of the infrared video ENG is caloric testing. The testing consists of a bilateral, bithermal irrigation of the ear canals with either water or air. In so doing, the horizontal semicircular canal is isolated and tested to determine if abnormalities exist, which may either be of a peripheral or a central origin. This is the gold standard for evaluation of the horizontal canal because it is possible to isolate the canal from both the posterior and the superior semicircular canals. It is assumed that if there is disease in the horizontal semicircular canal, that the other two vertical canals are diseased as well. Before beginning this test, it is of primary importance to make sure that the ear canals are cleared of cerumen and that the eardrum is unobstructed for stimulation with the cool or warm water or air. In addition, it should be determined at the time of the pre-testing examination whether or not infection in the skin of the ear canal or a perforation of the tympanic membrane may be present. In the case of patients who exhibit no response, typically after repeat testing with warm or cool water or air, ice water testing is recommended, as this is a test of pure cerebellar function and can be useful if the rest of the testing is negative. In each irrigation, nystagmus with a slow phase velocity of less than 10 degrees per second is abnormal. Other parameters are also examined, and calculations are done of unilateral weakness, of which 25% or greater is abnormal, and fixation suppression, in which the patient is determined to be unable to suppress at least 50% of the nystagmus when 2 or more irrigations may be abnormal. There is also an additional parameter which is measured, which however is of no clinical significance, that being directional preponderance. A unilateral peripheral vestibular lesion will be demonstrated when one ear's unilateral weakness is 25% or greater. If both ears demonstrate a caloric weakness of greater than 25%, this is indicative of a bilateral peripheral lesion. In addition, a non-localizing central nervous system finding may be elicited if there is failure of fixation suppression. In this example, a caloric cool right maneuver has been performed, which has elicited very brisk sawtooth nystagmus in the horizontal plane with a frequency of 19 beats to the left per 10 seconds. This is clearly a normal response and demonstrates good function in the horizontal canal in this particular test subject. It will be noted that there is no response in the vertical channel, which is also a normal finding. This demonstrates stimulation of the left ear with the cool caloric testing modality. There is again noted brisk sawtooth nystagmus of 21 beats to the right, which is the expected direction of the fast phase of nystagmus with caloric cool left testing. In addition, there is no vertical response in this particular subject in the left ear, which is a normal finding. This again demonstrates normal caloric response to cool stimulation on the left. The following patients' data are presented as additional examples of findings during caloric testing both normal and abnormal. In the first two patients, we demonstrate brisk caloric responses in both ears, which are indicative of normal function. In the first example, this patient demonstrates a brisk nystagmus response in both ears with warm and cool calorics. In the caloric warm left and caloric cool left, we see a slow phase velocity of 47 degrees per second and 37 degrees per second, caloric warm left and cool respectively. In the right ear, a similar type of finding with a somewhat lesser magnitude is also observed with slow phase velocity of 13 and 14 caloric cool right and caloric warm right respectively. In the second patient, we again see very brisk responses in both ears, also indicative of normal function. In the next 12 examples, we see extremely poor caloric data, which is typically the result of technical difficulties such as problems with irrigation, excessive cerumen being present in the ear canal, infection in the skin of the ear canal or involving the tympanic membrane, or other abnormalities. It is of paramount importance to be certain that the ear canal is unobstructed and that no other obvious impediment to adequate irrigation be present in order to assure that the data is optimal. The next patient demonstrates a central type vestibulopathy where there is failure of fixation suppression. In this particular patient, we also see a marked vertical nystagmus, which is also indicative of a more central type pathology than peripheral. In these particular patients, it is again of extreme importance to be observing the nystagmus pattern and the absence or presence of nystagmus when fixation suppression maneuvers are carried out. In the last patient, we see significantly diminished responses in both ears. This is indicative of a bilateral vestibulopathy from ototoxicity that the patient sustained after being treated with a prolonged course of aminoglycoside antibiotics. In this particular case, we see that the responses are not completely absent, but however are suboptimal and indicative of a more elderly patient with bilateral ototoxicity. We at MedTrak sincerely hope you have found these instructional videos to be of significant importance in promoting the success of your vestibular and balance laboratories. However, it should be noted that these videos are not a substitute for a formal training course, but are intended primarily as supplemental educational materials. It is extremely important to participate in a formal instructional course, which is typically done during a weekend setting, so that both anatomy, physiology, testing modalities, as well as technical points are reviewed and learned by the participants. Thank you for your attention.